friends. Today we are discussing an important issue. Namely, in a terminally sick patient, are we prolonging life or we are delaying death? This is an important dialogue which was every day during my residency. On one or the other sick patient, Dr. Eggleston would announce. Dr. Forrest Carey Eggleston had a vision of academics and research even 42 years ago when I met him. He had the thought process of palliative care and hospice care, in his words, which were accepted in America later than that. So, being his true resident and a fellow, I felt like, out of a discussion on Facebook, that we must discuss this issue. Today we are going to discuss the end of life issues as relevant to our country. We cannot have the whole country insured. We cannot have the same rigid principles, but let's try and discuss out what all can be achieved or has been achieved. Imagine you are flying at 36,000 feet in the air, and with sudden large thud, the plane goes 10,000 feet down, and while you were reading your book and you take your head out of window and you see one of the engines is on fire. Friends, exactly same is the situation when someone who is having a happy, nice life is suddenly diagnosed, welcome Dr. Gilani, suddenly diagnosed to have a malignant process, localized or metastatic. The news of malignancy in somebody's life like a fire in an aeroplane. Yes, in this situation, the patient has to co-pilot. The destination may have to be changed. The clinician has to take the journey along with the patient to make his life as comfortable, as humane, as wishful as possible. And today's discussion is meant at primarily the importance of palliative care and hospice care in any patient who has a terminal disease or a far advanced disease. We need to sync our priorities and thought process as much as the patient thinks. We are supposed to talk and deliver hope. We are supposed to act as his brethren, or as we will act with our brethren. Friends, there are three issues of healthcare delivery in such situation. Number one, making patients' experience of his disease process of hospital establishment and healthcare workers as best as possible. Number 2, to take care of our country fellows' healthcare. And number 3, to decrease per capita expenses on such situations as low as possible. It is interesting, we don't have any Indian data, but as per American data, 15% of GDP is spent on 15% of terminally sick patients in ICUs, where that amount of expenses are not only taking away the country's hard-earned tax-paid money, it also has a lot of repercussions which we are going to discuss. The concept is as if a patient asks to a surgeon for a patient who is undergoing right hemicolectomy for a stage 2 or 3 carcinoma colon, if the patient asks, "Doctor, do I need to go to a palliative care?" We have a fixed mindset. He said, no, right now it is my area. Palliative care is much, much later. No, we want to emphasize that it is a concurrent palliative therapy. While the patient is undergoing active surgery, chemotherapy, along with the medical oncology, if we start simultaneous palliative care, the results are much better. To quote a study, the landmark study has been done by Mass General Hospital and is published in New England Journal of Medicine. They studied carcinoma lung. Half the patients were treated with medical oncology and definitive care, and the rest half were treated same time with palliative care. People who were treated in palliative care simultaneously has lesser hospital admissions, had less ICU stay, they had less pain, less depression, they spend more time at home, and they lived 25% more life, that too at their home. And in their last 2 weeks of life, they were not on chemotherapy. So, we are in a momentum to do something good for the public, for our patients. The philosophy is simultaneous palliative care. What we want is all the best of care to all the patient all the time. But it does not happen like that. And at times we feel helpless. The clinicians, it is evaluated, when we talk to oncologists and oncosurgeons, they sometimes estimate 500 times more survival than what actually happens. They are over optimistic and were reluctant to inform the patient the truth of life. Now, what was the difference? All those who are interested can read Dr. Atul Gawande, who's done a lot of work on this. And now we have two types of clinicians. The definite care guys who are trying to increase the quantity of life. And we have palliative care physicians who are going to increase the quality of life. In Indian system, we cannot have and we do not have many palliative care physicians across our country. So what I am trying this evening to awaken my youngsters and my younger generation, that each one of you as a surgeon who is dealing terminally sick patients, try, like you learned laparoscopy, like you rotated in plastic surgery, take it as an option to learn the palliative care. You know what is palliative care? Is just being humane, be available, create a team, listen to the patient, listen to the family, what their priorities are, make their time. You see, in terminal patients, you may not be able to add days to the life. I repeat, in a terminal patient, you may not be able to add days to the life, but you can always add life to the days left with the patient. So, as surgeons, as definitive people who fix the fixable disease process, we talk more. What the palliative care requires is ask and listen more. What you want when you approach such a patient. The set common questionnaire would be, Mr. Gupta, what do you think in your disease process where you are? When you're going to talk to such a patient, their daughter, their son, their loved one, before you reach the patient will tell you, doctor, don't tell our father that he has cancer. Now, the truth is, all patients know what they have. And the role of palliation is to first evaluate what the gentleman thinks about himself. So if you ask, what do you think, where we are in this disease process? The fellow would say, invariably, I'm in hospital for last 3 weeks. I've undergone surgery. I'm getting weak every day and my appetite is going down. I'm losing my hair. So I'm downhill. So the next question is, what your fears are. He will narrate his fears. I apprehend that I may die soon. I may lose my life through my lung or through my abdomen. My pain is every day increasing. Now here he has given you the first food for thought. His issues are, he is having pain, he is having sleepless nights, and what are his wishes? What would he like to do? Then, if I have to elaborate, between a definitive care is, when you say definite care, that means you lose your next 3 months to have a gain later. Whereas the palliative care says you get your current time the best at a bargain of losing something later. So when you talk to the patients, what your wishes are, maybe somebody will say, I have my son in England, and I would love to meet him before I leave this world. Somebody might say, I would love to see my daughter's wedding. Then the clinician asked, when is the wedding? Then the answer is 6 months from now. Now, a wrong statement would be, oh, doesn't matter, you will surely see your daughter's wedding. When you know, and the patient also knows, that those 6 months are never going to come back. So when you come out in your counseling room, talk to the family, talk to the daughter. The daughter also says, I would love my mother to attend my wedding. Now there has to be, what is palliation is, we want the end of the patient in a happy mode and the family to have less of stress, less of depression. And the lady cannot be taken for 6 months forward with her life, at least not without ventilators, and unconscious without knowing any celebration. But the marriage can be preponed. Bring the marriage anterior and let the daughter get married in next 2 days if it is feasible. Take care of the symptoms. If the patient has more pain, more vomiting, losing appetite, take care of those things. In a definitive care in our hospitals, sometimes the false hopes which we are giving, now when you explain a patient, suppose an 85 years man who has diabetes, hypertension, 2 stents in his coronaries and has a leaking aortic aneurysm. If we don't operate, 100% of them will die. If we operate, maybe 50% will die perioperative. The rest of them will have aggravation of their cardiovascular disease, their hypertension, their renal failure, maybe on permanent replacement therapy, and their quality of life is never going to get back. Now it's the way how you explain the patient. I must share with you an example. A 85-year Alzheimer lady which was dependent in wheelchair, people taking care of her. Suddenly the family noticed that the lady is breathing at the rate of 4 to 6 per minute, has become unconscious. So they rushed her to the hospital. 85, coronary, Alzheimer, obese. Now, the casualty medical officer in Indian scenario would say, look, your mother is very serious. She needs ventilation. Whatever we may do, she has a remote chance of surviving. But if you want, what would you like us to do? Would you like us to do everything or nothing? That's the usual dialogue in usual hospitals every day. Now, that is the typical clinician approach. Elderly, obese lady with coronary artery disease, Alzheimer, grossly hypoxic, breathing 4 to 6 per minute. Sure, she requires everything. What would the outcome after putting all the resources? Very poor. Now, what should be the palliative care in such situations? The palliative care would talk to the family. What would you expect your mother and what would you think about her? The daughter may say, I just came from the market. I brought a nice dress for my mother. Then, when you explain the palliative care clinician, is there anything by delaying her death? We cannot prolong her useful life. But putting her on ventilator, something may happen 3 weeks from now. What might happen this evening? Would you like her to be on ventilator with a dismal outcome? What would the family like? And the answer would come. The daughter said, I had brought this nice pink gown for my mother as she wanted to wear this. The palliative care would get that gown on and say we would keep her in one room, we'll give her oxygenation, pray for her, and the family sit next to her so that she peacefully leaves the earth. That is called palliative. The palliation, this is a short story, but the palliation in a malignant process, in a grade 4 heart failure, in a renal failure should start very early. The early palliation leads to lesser hospitalization, less cost, less stress to the family. Then the last situation is the palliation takes the care to the patient's home. And the next level of care is hospice service. Started only 40 years ago, but as I learn more and more about the caring of dying, I'm amazed how much Dr. Eggleston could think much earlier than that he would like to know. He would ask us that what would this patient like? How does the family want? He used to say, we cannot prolong life, but we should make his days better, as many days he had. I still remember a scene around 1 a.m. in a surgical ICU. As a chief resident, I was doing a tracheostomy on a patient who was on ventilator for more than 6-7 days. Tube was getting blocked repeatedly. A patient who has child C liver disease, portal hypertension, variceal bleeding, hepatic coma, and poor renal function. So Dr. Eggleston just was walking by. He put his hand on my shoulder. He says, Giri, what you're up to? I explained him the case. He says, has this fellow a right to die peacefully? I said, sure, boss, but the tube is getting blocked. That's why I'm doing a tracheostomy. He said, will tracheostomy prolong his life or delay his death? He went out with me. He talked to the family, explained them, and the family consented so that the guy leaves the Mother Earth peacefully. The hospice service is another area which I want to touch. When a patient has a reasonable calculation by the clinician, not surviving more than 6 months, his second, third line chemotherapy has failed, his heart failure has progressed from third to fourth stage, he's on oxygen. And remember, hospice is not an alternative to death. It is buying time. It is giving dignity to a person during his last time. And it is taking all the services to the patient's home. We cannot follow an American system, but I would share you all surgeons can do hospice service in their community. You need somebody who knows about it, that should be a surgeon. The family should be educated while the patient is in hospital, how to take care of his pills, preventing his bed sore, taking care of his catheter, taking care of his nasogastric or a J-tube feeding. Let him listen to the best of music he likes. Let the pet stay next to him if he had a favorite pet. And arrange a paramedic help to visit that patient maybe twice a week or SOS. There should be a local doctor. Some practitioners in the neighborhood village, I invariably call them over when the patient is still in hospital and ask them to come maybe once or twice to learn some finer details. And if the terminally ill patient accidentally happens to be a diabetic also, at times giving him one more sweet or something which forbidden in diabetes, if the patient wants to eat, allowing him to eat that much will not harm him. If his end becomes happy, let him watch his favorite TV shows, listen to the music, let the family and friends sit next to him and make his journey comfortable. Now, having said all that, the important thing I'm repeating again, when we talk to the family, when we talk to the patient, it is important to know what his priorities are, what are his fears, what are his goals, and what is the trade-off. Suffering versus some additional time. And there are people, very recently, only a couple of months ago, I learned that diabetics who have foot ulcers, comparing the choices, an ulcer under the first metatarsal head is a difficult thing to treat. And if there is no active sepsis, and if you ask those, there is a study which said if you ask those people, will changing this ulcer, if you did not have this ulcer, or by a advanced plastic surgery technique, we took care of this ulcer, will it make, or how much difference it will make in your life? We surgeons are only targeting all our energy at fixing at the problem which we look at. We forget this patient also has severe osteoarthritis, he has grade 2 heart failure, he has renal failure, he cannot walk anyway. So why you expose this man to a high-end surgery? Let him live with the ulcer or with a straightforward amputation so that he is home in a day. Palliation is looking at the whole body as a unit. Surgeons look at only the fixable problems. We should not only look at the fixable problems, not only look at the holistic human body, we should also look at that if he was our friend, our relative, our buddy, what we would like to do. Whenever I meet people in surgical ICU who are sick, When I talk to the family, I always start with a note. Friends, I appreciate your concern for your dad. I know how much worried you are. If I was in your phase, I would be equally concerned. And in this life, I have lost my loved ones. I know how it feels like. So we need to be empathetic. We have empathy when we talk to people. The crowd will always respect you. Keep the cafeteria approach open. At the same time, be realistic. Do not suggest $1 million drug which is yet experimental. This happens on oncology. They would say this injection 2.5 lakh rupees per dose, 12 injections, 30 lakh rupees. Now look at a man, this highly qualified All India Institute oncologist is talking to a clerk's wife. A 44 years clerk is dying of a metastatic cancer, and this fellow is giving a false hope, not looking at that with 2 children, non-working wife. Such a suggestion is not only not going to work, it is also going to leave a lifelong guilt feeling in that young widow's life, that if I had 30 lakh rupees, my husband would have been alive. So friends, let's practice surgery more humane. Start palliative care much earlier. Hospice care in time. It is no excuse that in India the hospice care cannot be practiced. Yes, we do not have structured hospice care, but 75% is better than none, if not 100%. At the same time, at the time of distress, involving a religious preacher also helps. I have suggested several times in my motivational lectures to several hospital organizations, yet this concept has not entered the head of administrators because they look profit in everything. And humanity only gets you more business in the long run. So at times I also double up as a preacher, quoting scripture and counseling them so that the family is not under stress. It's also a good gesture to have a feedback call to the family after a month or after 2 months to know how everybody else is doing. If you've done your job well, a feedback call to the family would give you knowledge not only to upgrade yourself and your services, it goes a long way in relation building. Thank you very much for being with me this Sunday evening, and if you have any questions or suggestions, please surely mention. I would like to reply back. Okay. Thank you. Have a nice week ahead.